Hello, good evening, everyone. Thank you for joining us for this webinar series. So, this webinar series will be in three parts. Today is the volume one. We'll have the volume two in the month of May, and then volume three in the month of June. So, the volume one is on ERA, a proven solution for recurrent implantation failure. We'll discuss about ERA used by over 3,000 clinics worldwide. Is the only endometrial receptivity test backed by a randomized controlled trial. Our speaker for today is Dr. Tiffany. Dr. Tiffany is the Endome Trio Product Director for iGenomics. So it's my pleasure to introduce my colleague, Dr. Tiffany. Tiffany earned her bachelor's degree in animal bioscience from Pennsylvania State University and PhD in genetics from University of Kent, where her thesis centered on optimizing IVF outcomes by controlling for both embryonic aneuploidy and endometrial receptivity using genetic testing. Tiffany has over 15 years of clinical laboratory experience as a fully trained embryologist and is certified by the American Board of Bioanalytics and as a technical supervisor in both embryology and andrology. In addition to clinical laboratory experience, she coordinated many aneuploidy and single gene cases as PGT director at a large IVF clinic in Philadelphia. Tiffany made the move to reproductive genetics in 2016 when she became the PGTA lab manager at iGenomics New York. In 2017, her primary focus in the company shifted to endometrial testing when she took on the role of endometrial specialist, concentrating on ERA, EMA, and ALICE tests. Today, she serves as the global endometrium product director for iGenomics. Tiffany has published and presented research at conferences such as the Pre-Implantation Genetic Diagnosis International Society, the American Society of Reproductive Medicine, the European Society for Human Reproduction and Embryology, and the Pacific Coast Reproductive Society. She is an instructor at Eastern Virginia Medical School and is a member of the American Association of Bioanalysts, the College of Reproductive Biologists, and the American Society of Reproductive Medicine. So, welcome, Tiffany. Uh, we have 16 participants. I think we should wait for some more time. Number increasing. Just if you can give us 2 minutes before we start. I would like to tell everyone you have a icon on top for questions. Once the presentation is over, please during the presentation, any question that you have, you can post it in the question icon and we will take up all your questions after the presentation.
Thank you, Bertati, for the introduction. So we'll wait 1 more minute, and then if you give me the A-OK, we'll go ahead and get started.
Sure.
On top of this, this webinar and the volumes following will be recorded and published on our ERA hub, and you'll also receive the recording as a registered attendee. And then as a reminder, again, what Bertati mentioned, please, if you have any questions during the webinar, go ahead and enter them, and then we'll review them at the end. All right, so we're about.
Okay, I think we can start, Tiffany, once you're ready. Get started.
Perfect.
It's already 7 minutes.
All right. Well, thank you everyone for taking the time to attend today. And thank you again, Bertati, for the introduction of the webinar series and to introduce me to everyone. So as Bertati said, we're kicking off our Y Era webinar series. This is the first volume entitled Era, a Proven Solution for RIF. So as Bertati mentioned, ERA is used by over 3,000 clinics worldwide and is the only endometrial receptivity test backed by a randomized controlled trial. So let's start with a quick introduction. I think we're all well aware that implantation itself is a significant rate-limiting step in both human reproduction and IVF. So down to the basics, what is the equation for success? We know that the equation for success is both an optimal embryo, but also an optimal endometrium. We can have the most perfect, morphologically ideal blastocyst that's chromosomally normal, but if the endometrium is not optimal as far as receptivity or perhaps microbial environment, that embryo most likely will not implant, and vice versa. We can have a great endometrium, but if we have a very poor quality embryo that is aneuploid, we will also have failed implantation. So really, it's both the embryo and the endometrium working together to optimize clinical outcomes for our patients. So let's take a look at recurrent implantation failure, or RIF. Now, according to the European Society of Reproductive Medicine and Embryology, they published their good practice recommendations on recurrent implantation failure back in 2023. How they defined rift was based upon first, what type of embryo was being transferred in those failed implantation cycles. So considering euploid embryo transfer, RIF is defined as transfer of two euploid embryos regardless of the age of the patient. Now, if we're talking about embryos of unknown euploidy, so embryos that have not undergone PGTA testing, then RIF depends upon maternal age. So transfer of three embryos in women greater than 35 years old, less than 35 years old, transfer of four embryos in women between 35 to 39 years old, or the transfer of six embryos in women greater than 40 years old. As far as the causes of RIF, we're quite familiar, and what Escher points out is that multiple factors and causes of RIF have been suggested in study. And some of these examples include embryonic factors such as chromosomal aneuploidy, lifestyle factors, for instance, obesity, hereditary factors such as thrombophilias, and endometrial factors such as receptivity. Now, when we look at the occurrence of recurrent implantation failure, we know that RIF affects approximately 10% of couples undergoing IVF, so about 1 in 10 women. After the third failed cycle, there's been reporting of 22 to 50% dropout rates for couples undergoing IVF, and this increases with each consecutive cycle. So we know in this particular indicated population that these couples tend to get exhausted quite early within their IVF because of the multiple failures and tend to cease treatment. In many cases, couples suffering from recurrent implantation failure are desperate to do something different. They want to effectively address and overcome their implantation failures. They really want a solution that works. So going back to Escher's good practice recommendations for recurrent implantation failure, they do have a list of investigations for RIF that can be performed. And how they published this was based upon a street light format. So green meaning they recommend, yellow can be considered, and red, there's not enough data right now to support the uses of those particular investigations for this patient population. So the examples I listed here are the yellow and the green. So what can we do for RIF patients? So investigation of RIF should include investigating both the female and male partners or factors. And examples could be recommend reviewing lifestyle factors in both partners, Reassessment of endometrial thickness is also recommended. You can consider karyotyping of both partners to confirm the absence of chromosomal abnormality in parents, so looking for translocations, for instance. Endometrial functioning tests such as receptivity or the ERA test can be considered. And you can also consider an analysis for chronic endometritis. So this would include tests such as EMMA and ALICE. So today we're going to focus on endometrial function testing, specifically the ERA test. So let's look at endometrial receptivity testing as a solution for RIF. So the ERA test was introduced back in 2011 with a publication from Diaz-Gimeno et al., with the objective to create a genomic tool composed of a customized microarray and a bioinformatic predictor for endometrial dating and to detect pathologies of endometrial origin. They wanted to define the transcriptomic signature of human endometrial receptivity. And what the conclusions of this first paper showed was that this diagnostic tool could be used clinically in reproductive medicine and gynecology, and the transcriptomic signature is a potential endometrial receptivity biomarker cluster. Now, 2 years later, Ruiz et al. Published a prospective study looking at the clinical utility of the ERA test in RIF patients. Here, the objective was to demonstrate the clinical value of the endometrial receptivity array, or now we refer to as endometrial receptivity analysis, in patients with repeated implantation failure for guiding their personalized embryo transfer, or PET, as a novel therapeutic strategy. And the conclusions here showed that there is an increased percentage of window of implantation displacement in RIF patients compared to a comparison group of good prognosis patients, so those patients without a history of implantation failure, leading to the concept of PET, or personalized embryo transfer, as a therapeutic strategy. There's rescue of non-receptive patients by PET and displaced window of implantation results in similar pregnancy rate and implantation rate. So effectively showing that the clinical directive associated with the ERA test was effective to overcome previous implantation failures in those patients. Now, what is ERA? I think we're all very familiar with ERA, but we'll go through a quick introduction. So as I mentioned in the previous slide, first introduced in 2011, ERA, or endometrial receptivity analysis, it's the world's first molecular assay used to determine each woman's unique personalized embryo transfer timing, therefore synchronizing the embryo transfer with the individualized window of implantation. How does ERA work? Well, we use next-generation sequencing to measure the expression of 248 genes evolved in endometrial receptivity. Now, we get questions, why use NGS? NGS is more automated and standardized and less prone to errors versus other methods that may be used for endometrial receptivity testing. Why 248 genes? Well, the analysis, including 240 genes, is the greatest number of genes that are studied with endometrial receptivity testing. And why is it important to have that many genes? Well, it's important because we need a reliable assessment of such a complex mechanism such as endometrial receptivity. When we lack a sufficient amount of genes for study, we may be missing out on accurate findings for the patient as far as receptivity goes. And then we specifically measure the genes associated with human implantations directly. Those are what those 240 genes encapsulate. Now, following next-generation sequencing, an in-house designed computational predictor analyzes the data that we obtain and then classifies the endometrium as either receptive or non-receptive. So a note about our computational predictor. This is an AI-powered algorithm that's continually refining with clinical cases and data. At this time, we've examined over 200,000 women worldwide with ERA, more than any other endometrial test. And this contributes to superior accuracy of the test because we're always feeding the system with patient data. And then receptivity diagnosis is not only based upon gene profiling, but is further paired with the data from successful pregnancies. So this is a little unknown fact for some, is that when we give our results of receptive, it's not only based upon the previous experience we have looking at the transcriptomic profiles of women with receptive transcriptomic results, but also based upon those women who were receptive and transferred accordingly and had a successful pregnancy. So it really strengthens the recommendation given by ERA, where we just don't base it upon transcriptomic profiling, but also clinical outcomes. And then finally, the result is coupled to a recommendation for a personalized embryo transfer, or PET, according to each patient's specific endometrial profile. We give a clear clinical directive with the most precise transcriptomic profiles. So as many of you know, we even see shifts of just 12 hours. This would be an example, our late receptive phase, which we know women who are late receptive and transfer at the late receptive time have experienced a higher tendency for biochemical pregnancy loss. So those minute changes are important for a subset of patients. And this provides superior personalization for patients' transfer timings. It's also supported by a team of internal experts, including IVF nurses, IVF physicians, scientific advisors, genetic counselors, and dedicated endometrial specialists. So, who is ERA for? When we're talking about ERA only, we are indicating specifically for patients with recurrent implantation failure. This is why the ERA test was designed to help these subset of patients. So let's go into why ERA is a proven solution for RIF. So I want to start by defining what does a proven solution mean? Well, according to NIH, randomized controlled trials, or RCTs, are the gold standard in evaluating the effects of treatment. To be clinically meaningful, results must be relevant to a specific patient populations in specific settings. So this is very important to keep in mind as we go through some of the data. So we see our pyramid down here in which RCTs are one of the top priorities as far as study design in actually accepting a treatment. So ERA itself has 3 RCTs that have been performed. So remember from the previous slide, we have randomized controlled trials are the gold standard, and we need to keep in mind specific patient populations. So let's look at the 3 RCTs that have been published about ERA. The first was Simone et al., published in 2020. This was a 5-year multi-center randomized controlled trial comparing personalized, frozen, and fresh blastocyst transfer in IVF. The conclusions here stated that despite 50% of patients dropping out compared to the 30% initially planned, this dropout rate was due to mostly no protocol compliance. The per protocol analysis demonstrates statistically significant improvement in pregnancy, implantation, and cumulative live birth rates in the PET group compared to the FET and fresh embryo transfers without ERA, indicating the potential utility of PET guided at the ERA test at the first appointment. So after this study was published, another RCT was conducted to further the understanding of these results. And that was published in 2022 by Doyle et al., or the Shady Grove Fertility Group in the United States. And this paper was entitled Effect of Timing by Endometrial Receptivity Testing versus Standard Timing of Frozen Embryo Transfer on Live Birth in Patients Undergoing In Vitro Fertilization, a Randomized Clinical Trial. Now, what the Doyle group found was that among patients for whom in vitro fertilization yielded a euploid blastocyst, The use of receptivity testing to guide the timing of frozen embryo transfer compared to standard transfer timing did not significantly improve the rate of live birth. The findings do not support routine use of receptivity testing to guide the timing of embryo transfer during in vitro fertilization. And then the most recent RCT, published in June 2024 from Barbacazzi et al., entitled Assessment of the Role of Endometrial Receptivity Analysis in Enhancing Assisted Reproductive Technology Outcomes for Advanced Age Patients, concluded that PET guided by ERA significantly improves pregnancy, implantation, and live birth rates in advanced age patients with challenging reproductive histories. PET provides ART outcomes with no significant difference between advanced age patients and younger patients with PET guided by ERA. So we have three randomized controlled trials for ERA, two showing good results and one showing no difference whether you transfer at according to the PET or the standard timing. So very neutral results. However, as I stated before, the results must be relevant in a specific patient population in specific settings. And since the ERA is specifically indicated for RIF, we need to focus on the data in this indicated population. So when we consider the patient populations in all these RCTs, we find, well, Simone et al. Was not in the indicated RF population, but instead the good prognosis patient population. These were patients undergoing their first IVF transfer. What about Doyle? Same thing, good prognosis patients, not the indicated RAF. In fact, RAF was a clear exclusion criteria in the Doyle et al. RCT. And then that leads us to the most recent RCT by Barbacazzi, in which the patient population was specifically the indicated RIF population. So today we're going to actually focus on the most recent RCT, as that is the only ERA RCT performed in the indicated population of RIF. So looking at Barbacazzi et al. 2024, the objective here was to improve ART outcomes with personalized embryo transfer according to the ERA test in advanced age patients with challenging reproductive histories and RAF by utilizing donor oocytes and pre-implantation genetic testing for aneuploidy or PGTA for embryo testing. So this is really great because we have been asked for years, what happens when we control for embryo aneuploidy? How are our ERA outcomes? And as we know from the introduction, having an optimal embryo and an optimal endometrium can only translate to optimal implantation. So this is the first study, as I mentioned, in RIF population that utilizes PGTA to control for embryo factor while assessing the effects of the ERA test on implantation. So looking at the study design, this was a randomized control observational trial. The study duration was from 2020 to 2023, and it included 320 patients with RIF. And how the authors defined was that these patients specifically had to have a previous euploid failures. And these patients were allocated into one of three groups. One was a study group, two, control group 1, and then the third group was control group 2. So looking further, let me see if I could put my pointer on here. If we look at the study group, these were women aged 35 to 45 years old, so a clear definition of advanced maternal age. And the women in this group had donor eggs, but underwent PGTA testing on the resulting embryos and ERA for a personalized embryo transfer. In control group 1, These patients were also advanced maternal age, between 35 and 45 years old. They used donor eggs, and then the resulting embryos went under PGTA testing. These women underwent a standard FET and did not have ERA testing performed. And then finally, control group 2 were women under 35 years old. Since these were younger women, they used autologous eggs. So we had a comparable age of eggs between the 3 study groups. And in control group 2, they also underwent PGTA testing and ERA testing like in the study group. So what did the results show us? So just to explain the graph here, this dark blue indicates study group 1. So again, your AMA patients undergoing PGTA plus ERA. The peach color indicates control group 1, so AMA patients with PGTA only. And then the lighter blue color is control group 2, which are your younger patients than 35, and they underwent PGTA plus ERA like the study group. Now, looking at the clinical rates for pregnancy, we found that there was a significant improvement in pregnancy rate for PGTA plus ERA versus PGTA alone. So comparing 77.9% pregnancy rate in the study group versus 57.6. Now, what's also interesting is that we see that there's comparable pregnancy rates between the study group and control group 2. So remember, control group 2 was just your younger patients, but still utilized both PGTA and ERA. The same trend was also found for implantation rate, where we had a significant improvement in implantation rate for PGTA plus ERA versus PGTA alone. And then also live birth rate, where we can see a significantly higher live birth rate when utilizing ERA plus PGTA versus PGTA alone. So comparing specifically study group to control group 1, the study group had a 71.3% live birth rate versus control group 2 that only had a 39.4% live birth rate. So the conclusions from the Barbacadze et al. RCT was that personalized embryo transfer guided by ERA significantly improves pregnancy, implantation, and live birth rates in patients with RIF, including those of advanced maternal age. So remember, we saw significantly higher in the younger than 35 and the 35 to 45-year-olds. Another conclusion is that with no significant difference in clinical rates between the study group and control group 2, using ERA with euploid embryo transfer overcomes poor reproductive outcomes associated with advanced maternal age, normalizing them to those achieved by younger patients. So I think this is very important. We tend to note that women with advanced maternal age um, uh, do have a higher displaced window of implantation. This is something that we've seen and other groups have seen. But is this a reflection of endometrial aging, or is this a reflection of their multiple years of recurrent implantation failure? So not only do these conclusions deliver results for any patient undergoing RIF, but we also see an advantage for those patients with advanced maternal age. So what are the key points to take away from this recent RCT? Well, again, as I've stated to previous times, randomized controlled trials are the gold standard in evaluating the effects of treatment. To be clinically meaningful, results must be relevant to a specific population in a specific setting. So RIF is the indicated population for ERA. The Barbacadze et al. Is the only ERA RCT conducted in the indicated population of RIF. And the ERA test specifically is the only endometrial receptivity test backed by a randomized controlled trial. In fact, again, we have 3 RCTs and one specifically in the RIF population. So, what about further scientific and clinical support for ERA? As I mentioned, the title of this is a proven solution for RIF. We went through the top tier accepted RCT, but of course, there's other data supporting its use. So, since its development in 2011, the ERA test has been extensively studied with over 50 clinical trials supporting its role in personalized embryo transfer. In fact, you can find on our ERA Hub a link that will take you to all the publications conducted on ERA. And I included some of them here, both from internally from iGenomics and from external groups such as different IVF centers around the world. Now, what about for patients with recurrent implantation failure? So there are multiple studies that you'll find in that publication list specific to the RIF population. And to summarize some of the key findings in RIF from these other publications outside of Barbacazzi et al., is that one, ERA has the highest published clinical rates for patients with RIF compared to any other endometrial receptivity test in the market. RIF patients who underwent PET guided by ERA had significantly increased clinical outcomes versus those patients who did not undergo a personalized embryo transfer guided by ERA. RIF patients who undergo PET guided by ERA were found to have similar outcomes to those achieved by good prognosis patients. So similar to how ERA normalized clinical outcomes for AMA patients in the previous paper we looked at. In this paper, they did a direct comparison to patients without a history of RIF and found similar outcomes when ERA was applied to the RIF group. And then in a recent systematic review and meta-analysis that assessed 36 different therapies for RIF, the analysis included over 29,906 patients with RIF, showing that ERA is among the top therapy or intervention to improve implantation rate and live birth rates in this specific patient population. So this was a paper published back in 2023, and it looked at therapies, again, that not only included endometrial receptivity testing, but also other interventions such as PGTA or embryo glue use. Now, this is a question we get in the field. What about the controversial results? So not every ERA publication out there is supporting the use of ERA. So what about these publications questioning the clinical utility of the test? Well, here I listed the top 5 controversial publications. One was Tran et al. Published in 2022, followed by Casalino et al. In 2022, Arian et al. In 2022, Doyle et al. In 2022, and then rounding it out with Richter and Richter in 2023. Now, we can see the study designs of these included meta-analysis, a retrospective, another meta-analysis and systematic review, an RCT, and an opinion piece. But let's look at the study populations here. So in Tran et al., they looked at the ERA utility in various populations. In Casalino, 1 previous failed ET, so this was not the indicated population of RIF. In Arian et al., they did look at RIF population and good prognosis population. However, only 2 out of the 8 studies in the analysis included RIF population, and this was a specific meta-analysis for ERA, but the authors included a study on ER-peak, which is a different endometrial receptivity test. So really only 1 study for ERA when it came to RIF was included in this review. Doyle et al., as we had discussed previously, was in good prognosis patients, so they specifically excluded RIF patients. And then Richter and Richter was an opinion piece based upon Doyle et al. So again, no RIF patients were considered. So when we look at these publications, they're not even performed in the indicated population of ERA. with an exception of Tran et al. And Arian that did include one study of RIF, specifically using the ERA test. However, because of other errors within these papers, we're starting to see a retraction of some of these publications. Specifically, as an example, Tran et al., which was retracted in 2024, and we'll go through some of that data here. But let's keep in mind, so Tran et al. Was retracted. Casalino et al. Was in good prognosis patients, not the indicated RIF population, among other errors or discrepancies that took place. For example, the same group was involved in our RCT, in which the same patient population was applied, and very different results were obtained in this group when the data was interpreted properly. Arian et al., again, good prognosis, not RIF population. We only had one study on RIF, and it came from ER-Peak. Doyle et al., again, good prognosis, not indicated RIF population. And then finally, Richter and Richter, good prognosis patient, not RIF population. And furthermore, in Richter and Richter, there was some impartiality and bias. In fact, they made reference to the Tran et al. Meta-analysis, which has now subsequently been retracted. So let's dissect one of these studies and look at Tran et al. So this particular paper was a meta-analysis published in July 2022 in Fertility and Sterility. The conclusions claimed that ERA showed no significant improvement in IVF outcomes expected in live birth for patients undergoing the first IVF cycle. Fertility and Sterility officially retracted this publication on October 30th, 2024, following the discovery of significant errors. So what were these errors? Well, first, the authors triplicated the results in the analysis. The authors stated that there were 4 RCTs that were reviewed for ERA. However, 3 out of the 4 RCTs were in fact the same study. So they counted the same RCT 3 times. And then as you know now, there are only 3 RCTs supporting ERA, and one of which was not published at this time. Actually, 2 of which were not published at this time. They incorrectly stated that they analyzed patients with ERA versus patients without ERA. Now, this is a common misconception, but what they actually did here was that they compared patients that were ERA receptive versus patients that were ERA non-receptive, both of which underwent a personalized embryo transfer according to their own personalized window of implantation. If they truly wanted to analyze patients with ERA versus without, then they would have to analyze patients with ERA, whether they had a receptive result or not, but ensuring they all underwent a personalized embryo transfer, versus patients who never underwent the test at all. And that was not performed here. And then other issues existed, such as it was unclear how the studies were selected for this meta-analysis. And then the author stated that abstracts were excluded from the analysis, though abstracts were indeed included in their analysis when you broke down the actual publications that they used. So I'm going to round this out by going through ensuring optimal results for ERA. And I want to introduce the ERA Hub, which was launched last year. This provides resources to ensure proper protocol compliance, hence optimal results. In fact, if you recall last year, our ERA webinar series that we kicked off in April 2024 was a protocol compliance series webinar. You can find that on the ERA Hub here, along with other ERA protocol videos and Meet the Experts. We have tools such as the personalized embryo transfer calculator and the ERA clinical tool that can be used by both physicians and clinics to ensure reproducibility of results. We have expert testimonials and tips from our scientific advisors, news about ERA, such as our non-selection study that is currently going on, and our ERA publication list, which you can download, and have links directly to the PubMed where the papers can be found. And then we also offer endometrial pre and post testing webinars for patients. So patients can go and find out more information about ERA and ensure good results. Now, let's finish off with conclusions before we enter our question and answer section. So, one, successful implantation is a rate limiting step to successful pregnancy in both human reproduction and IVF, and largely hinges on an optimal embryo and endometrium. Recurrent implantation failure affects about 10% of the population of patients undergoing IVF, and patients affected by RIF are prone to drop out of IVF treatment and are eager to address the cause of their implantation failure. ESHRA good practice recommendation indicate that endometrial functioning tests, such as ERA, can be considered in cases of RIF. The ERA test was the first commercially available test addressing RIF of endometrial origin. Randomized controlled trials are the gold standard in evaluating the effects of treatments. To be clinically meaningful, results must be relevant to a specific patient population in specific settings. The only RCT in RIF patients that test endometrial receptivity testing specifically for ERA demonstrated significantly better reproductive outcomes for patients who use ERA plus PGTA versus PGTA alone. Furthermore, AMA RIF patients had similar clinical outcomes to younger RIF patients. ERA is the only commercially available endometrial receptivity test backed by a randomized controlled trial. And although controversial results have been published about ERA in the past, it's important to thoroughly comprehend the study design and the findings, as most of these studies were not conducted in the indicated population for ERA, which again is RIF, and possess significant errors leading to retraction. Ensuring proper protocol compliance is necessary to achieve superior clinical outcomes in RIF patients. The ERA Hub offers resources for clinicians and patients to deliver expertise-guided care and support to the premium endometrial receptivity option, ERA. So with that, I would like to thank you for your attention, and I would like to open up the forum for question and answer section.
Thank you, Tiffany, for such a wonderful presentation and summarizing some of the important publications that we have on ERA. So we have few questions here. Just to remind everyone, if you have any question, you can keep posting. We'll take up all your questions. So we have the first question. Do you suggest ERA for AMA patients, even if they didn't have any RIF in the past? So if an advanced maternal age patient comes for first cycle.
So we do see a benefit in advanced maternal age patients, and as I stated before, we do see a trend for higher displacement in advanced maternal age patients, and we're not yet sure, is it because of endometrial aging, or is it because these women tend to have more implantation failures or a longer history of it? But if it's a patient who is advanced maternal age and coming in for her first IVF cycle, um, she doesn't fall within the RIF indicated population for ERA. However, we need to consider, this is personalized medicine at its best. So we have to consider on a case-to-case basis. Is this woman, does she have a lot of embryos available for transfer? Have you performed PGTA and maybe she only has one euploid embryo available? We have a lot of physicians who opt to use the ERA test out of the purely indicated RIF population in those cases where maybe the patient only has one attempt at a transfer. So they want to ensure that everything is optimal, including receptivity and endometrial microbiome. So we're putting that one precious embryo back into the best possible scenario that will lead to implantation. So I wouldn't say AMA is a overall direct recommended indicated group for ERA, but I think it depends on a case-by-case basis that needs to be assessed.
Okay, perfect. Thank you, Tiffany. Okay, our next question is, Should ERA be considered for recurrent biochemical pregnancies or recurrent and embryonic miscarriages?
So let's talk about biochemical pregnancy loss first. So there was actually a paper that we published in 2017 that revealed a specific transcriptomic profile, um, had a strong correlation to biochemical pregnancy loss. And I mentioned that in the presentation today briefly, and that is the late receptive transcriptomic profile. So these are patients, when they undergo ERA, they get a late receptive result, and the clinical directive is to transfer 12 hours sooner. Now, what we see when these patients transfer um, during the late receptive uh, timing of receptivity, so not at optimal receptivity, but at late receptive, is that they have a significantly higher risk of biochemical pregnancy. So it appears that some sort of implantation is taking place, but it's a very weak implantation, and then the pregnancy is lost very early on. So ERA could be beneficial for patients with previous biochemical loss. And I think this is really important when you're considering which endometrial receptivity test to use, because ERA is the only endometrial receptivity test that goes down to the 12-hour increments. So you could be missing those subset of patients at higher risk for biochemical pregnancy if you're only going at 24-hour increments offered with other providers. So the late receptive, yes. So biochemical pregnancy, I would say, could benefit from ERA. Now, pregnancy loss with an established implantation, so miscarriage after 6 weeks, probably not receptivity, because receptivity, we're enhancing implantation. I would say, as far as endometrial factor for those cases with miscarriage or recurring miscarriage, would be Emma and Alice test. Because these tests are the Emma and Alice is not only indicated for RIF, but also indicated for cases of RPL. Because we know that a pathogenic endometrial microbiome can lead to pregnancy loss. So yes, for biochemical pregnancy for ERA, not for miscarriage, but other endometrial investigations such as Emma and Alice.
Okay, thank you. Okay, we have next question. If the patient is taking antibiotics during the biopsy cycle and will not be taking the same during the transfer cycle, can this impact implantation?
Not as far as the ERA. So we think that we don't have a study showing the effects of antibiotics on receptivity. Now, with that said, there's some questioning. Can cases of chronic endometritis or dysbiotic microbiome affect receptivity? And this is something that our group is investigating now, along with other IVF clinics. Um, so, in those cases where maybe a patient has an infection and then takes an antibiotic, and in theory, maybe it's affecting endometrial receptivity. We don't know. But as far as what we say now, we don't believe that the antibiotics will affect the reproducibility of the ERA results specifically. Um, and at this point, they don't need to be replicated in the mock cycle and the transfer cycle. But we do need to keep in the back of our mind how antibiotics can affect the endometrial microbiome and the bacteria that live there.
Thank you, Rafni. Okay, we have our next question. I'm getting repeated non-informative error result for my patient. If changing the type of cycle is not an option, as suggested by iGenomics, what else can be done for such patients?
So it's non-informative results. So we have three different no results type. There's non-informative, um, which that happens in very rare, so less than 1% of samples received. And that's basically where the profile doesn't match anything within our algorithm. And In those cases, a rebiopsy, we're able to get a valid result in over 95% of the cases. So usually a non-informative result is something innate to that cycle specifically, whether the patient maybe had some early endometrial bleeding or difficulties during biopsy. Now, the other two results that we get are insufficient RNA, and that's usually because there's not enough tissue in the sample, or non-valid RNA, which it's typically the opposite. There's too much tissue in the sample, and it's overwhelming the stabilizing buffer to preserve the RNA in the tissue. Um, in those cases, it would be best to understand what type of no result you're getting so we can accurately understand how to fix that in subsequent cases. But as far as a patient getting a no result and not wanting to repeat the mock cycle for biopsy and testing, there's really not much we can recommend because we don't have any data on when she is actually receptive. So ideally, it would be to take another biopsy, but I would recommend meeting with your scientific advisor. For example, Bertotti can help and look at those cases, and we can pinpoint to see what is going on, even if it's within that patient themselves. As I mentioned, the non-informative, it's usually cycle specific in that particular patient. And in most cases, over 95%, the rebiopsy will yield a valid result.
Okay, thank you. Okay, our next question is something related to rebiopsy. Rebiopsy recommendation and ERA reports in many of my patients are received. What is the reason? And can we skip sending the rebiopsy and follow the recommendation provided for the rebiopsy exogenous progesterone hours for the transfer?
So we ask for rebiopsies in less than 10% of samples received. And these rebiopsies are going to be because of either a pre-receptive 2-day result or a post-receptive result. Now, these particular transcriptomic profiles do not occur as much as, say, receptive or pre-receptive 1-day or late receptive profiles. So we just don't have the confidence level to say, okay, transfer with 24 hours less of progesterone or transfer with 2 days more of progesterone. Because sometimes we know how, every woman has a very personalized window of implantation. So if we take, for example, the pre-receptive 2-day result, maybe that patient only needs, let's say, 1.5 days of progesterone, not 2 days. Because if we do the 2-day, maybe she comes back as late receptive with an additional 48 hours of progesterone. And then we're putting that patient at a higher risk for biochemical pregnancy. So the ERA test is very precise. And being the first to pioneer the endometrial receptivity test, as I mentioned, we're backed by experts, including IVF nurses, IVF physicians, and endometrial specialists. We really want to ensure the most accurate results and the most personalized recommendation for patients. So whereas you could transfer 2 days more of progesterone, maybe this patient has a endometrium that evolves quicker than what we see compared to other women, and she'll get to receptivity after only 36 days. So we really want to do what's optimal for that patient. And as I said, ERA is a prime example of precision medicine, and that requires a little bit more detail when examining the results. Now, in the case of post-receptive, unfortunately, there are some cases that are performed without endogenous progesterone control. So if you remember, proper endogenous progesterone protocol for ERA is to measure endogenous progesterone within the 24 hours prior to the first intake of exogenous progesterone HRT cycle, ensuring it's less than 1 nanogram per mil. When we see this level is higher than 1 nanogram per mil, or we don't take this measurement, we could have an artifactual result. And that's usually tends to be post-receptive because that first um, rise in progesterone above 1 nanogram per mil is going to set the timer for the secretory change to a receptive endometrium. So we are assuming with ERA, not assuming, but we're also checking with endogenous progesterone that that first intake of exogenous progesterone sets the timer. But if the patient's already producing her own endogenous progesterone, that's going to trigger the timer before we start with the exogenous progesterone, which means we missed maybe 24 hours, we're off by 12 hours. Um, so in those cases where the patient already started producing her own endogenous progesterone early, we tend to get a post-receptive result. So are the post-receptive results we're getting true or are they artifactual? And in some cases, they're artifactual because of this lack of protocol compliance and early endogenous escape of the patient's own progesterone. So this leads to the less data we have to support saying, okay, transfer with 24 hours less of progesterone. So until we can have a higher um, accuracy rate with a direct recommendation, we're going to recommend the second biopsy to ensure that we're actually personalizing the embryo transfer for that specific patient. So that was a long answer, but I think it's really important to understand all the aspects as to why we recommend a second biopsy. And we don't say, okay, just go ahead and transfer, because we could be transferring at the wrong time if we say that.
Thank you, Tiffany. Okay, our last question. Uh, how do we collect the biopsy with the hysteroscopy, and what are the precautions that we have to take? Can normal saline affect, because that has to be introduced? Hello? Okay, I think we lost Tiffany. There is some issue in her connection. So before we conclude, if you have any questions, you can send your questions through email. We'll answer all your questions. And again, thank you so much for taking out time and joining us for this webinar series. Thank you.